Well, hello, everyone. I'm Dr. Megan Mello. I'm a family and obesity medicine specialist in Seattle, Washington. And I'm so excited today to be joined by my friend, Dr. Caissa Troutman. She's going to introduce herself, but we're going to have a really good conversation today, really sort of talking about obesity care, how our brain is involved with that, and sort of really some of the important parts that, we as obesity medicine specialists really want you to know. So, Caissa, welcome. Thank you so much for being here.
Thank you for having me, Megan. I'm so excited to chat with you today. Looking
Yeah.
forward to it.
Well, tell us a little bit about you, where you are in the country, and a little bit about your work.
Yeah, so I am a triple board certified obesity medicine and culinary medicine physician. I run my own direct care weight wellness practice here in central Pennsylvania, so a little bit further away from you, but I have a brick and mortar practice as well as a telemedicine practice, serving any patient that lives in Pennsylvania. Yeah. So my practice is fairly new. Before I opened my practice, I was the medical director of an integrated health system. But I decided to open my own practice because I really wanted to serve my patients in the best way possible that I know can, catapult them to a level of I would say journey in their journey that will really help them.
Yeah. Well, I think we share a common vibe there of knowing that we really wanted to provide really good, high quality care to our patients, and knowing that where we were, it just wasn't possible in the sort of traditional healthcare model. And I think so many of our patients have experienced that. We may have experienced that ourselves as patients, right? But certainly, the ability to sort of create these dynamic practices that are a little bit different from everything else has been really just wonderful for, I think, both of us, right?
Yeah, it's been amazing. I love, obviously I'm still in the starting phase, but I love already the impact I'm creating for my patients. Some of my patients have followed me, and I had asked them like, so, I saw you before. I was already amazing back then, but and then I see you
I
now.
Yeah, I have to like request my records and go through
But
them.
but so but I asked them like, how is it? How is the
Yeah,
difference between now and before? And they was like a thousand times different,
yeah,
because it is like a super individualized and adequate time and frequent follow-ups, which is I
right.
think what is key because as a person with obesity myself, because I talk about the obesity care not just from a professional standpoint, but even really from that personal standpoint. I think having frequent appointments or follow-ups is necessary, especially in the beginning when we're struggling, when we're unsure, when we're discouraged. So easy to
Right,
get discouraged,
right.
or when quote unquote things are not going well or going right, because it's just
Yeah.
human nature,
Yeah,
right?
that traditional follow, oh, do this and see me in 3 or 6 months. It's like that does not work for obesity. If that worked, we wouldn't have obesity problems.
Right.
It
Yes.
wouldn't exist. You're right. It takes more care than that. So tell us a little bit, you alluded to it, but you also have a personal struggle with obesity that you eventually triumphed over. But I think those stories are also really powerful for patients to hear. So tell us a little bit about that part of you.
Yeah, for sure. So I've struggled with weight or obesity my entire life. I mean, I remember even as a child being so I grew up in the Philippines. So there's a terminology that they use where kabachingching sounds cute, but it's actually not. What it basically means it's obese kid. I was called that my entire childhood, and I would lose weight, and I remember in high school I was thinner, and then I gained weight in college, and then lost the weight when I worked out, and then med school, pregnancy would gain weight. So I've always had that up and down story with weight, and when I would put my all my attention by watching what I'm eating, working out, and be really like 110%, I would lose the weight. But then life happens, right? So, and then I would slowly kind of taper off and regain all the way back. So that's been my story. It's something that I share with a lot of my patients. And
Yeah.
in 2018, that was for me a little bit of the pinnacle of my dissatisfaction, I would say. I'm only 5 foot slash half So I'm a little short. So it carries differently, I think, as well. And I know Southeast Asian as well. So the weight is
Genetics are a
a
little bit.
little lower, right? The BMI is a little lower cutoff. But I was at my heaviest. I don't even know what my heaviest was because I refused to get on the scale at that time. I was an urgent care physician. I was working 14-hour shifts. My kids were age 4 and 5. So I mean, all of that, I was the breadwinner, all that stress. Probably I was not sleeping. And it was just like this really big storm of like, I don't know, maybe not, but just like bad, just stressful stuff. And
Yeah.
at that point, I was just like, I gotta do something again. But this time, I applied the knowledge of science. I looked into why is it so hard to lose weight? Why am I having a hard time? So I dove into obesity medicine. I loved it. And really what I found in my own journey was realizing that, weight loss is not about willpower. Because if it was, all of us successful type A people would lose weight, but obviously
Right.
it's not. Right?
Yeah.
So that was so freeing for me. And I share that statement with all of my patients.
Yeah. It's not about willpower. It's not about, shooting on yourself so hard until you do it. Those messages have been so ubiquitous, right?
Yes.
Coming from healthcare professionals, coming from, the wellness industry of like, you just have to want it enough. And it's no, that's not science-based. That isn't helpful information, and it continues the shame cycle that people experience.
It really is that shame. Like, my God, I'm a doctor. Why can't I lose weight?
Yeah,
Right.
yeah.
So that kind of drove me into the science of the obesity medicine. And after that, so I did lose weight, and I have kept off. So I've kept off around 32% of my total body.
That's amazing.
And that actually drove me to actually practicing obesity medicine full time. And then this would be where I am now.
Yeah. Well, and I want to
Doing
highlight something that you said before, because you said that you could put 110% in, right? You're a high achiever, right? You're a professional. You've got 3 board certifications within medicine, right? So you're kind of this rock star person, and you know that you can put a lot of energy in, right? Meal prepping, planning what you eat, exercise, 110%, right? And we can do that for a while and have success, right? And then life happens, as you say. I think that, caring professionals and other caregivers, right? Whether that's parents or caring for aging parents or, any other thing, when we need to care for somebody else, right? That self-care piece drops off.
Yes.
Right.
Sure.
So we see that, certainly in, physicians, nurses, teachers, social workers, right? Like we can add the list up of caring professionals, in the professional role, but, then we've got certainly all these other responsibilities.
I
I'm
think even as
curious.
a mom,
Yeah.
as a
As a
mom, as a
mom, right?
woman, I think we're so
Right.
used to putting others first
Yeah.
over ourselves. Yeah.
Yeah.
Yeah. Such a hard place to be.
Yeah. Yeah. So let's come back to the willpower thing. If it's not willpower, what do you think it is? Where do we start?
Yeah. So I think so the way I always approach it with my patient is understanding is the gateway to number one, breaking the stigma and the shame. Because when you understand it, you lift that burden of it's my fault, I'm broken. Because if we try to create change from the I'm broken place as a starting point, everything we will be doing would be negative or broken anyway, because we're broken anyway. So why it would never work, right? It's like you're defeated before you even start, right? So first is again just breaking that stigma, lifting that weight, and then from there, it's not an excuse per se, right? It's just breaking it and then learning. Okay, now that I know how it works, what's the best strategic way to do it, right? So looking at it, and again, we're using science, looking at the science behind it. So, how I view it, and I think how modern science views the struggle with obesity is, again, it's not a myself thing, right? It is a medical condition that is actually based in our brain.
Right. Human bodies and brains struggle with this, not
absolutely.
Personal flaw.
Right. It's not a personal failing or a moral failure, but it's really and I always like to describe the similarities between other medical conditions. A common thing I use is like allergies.
Yeah.
Everybody knows allergies. Everybody has allergies. So if you have allergies and it's springtime, do you like blame yourself for sneezing? But you don't. You
Yeah.
would avoid the outside if you can. You take an allergy pill if you can, and you done with it. But
Yeah.
when it comes to weight, right? It's like, oh, I'm a failure. I ate this when I shouldn't
You
have.
are
I
working
didn't do
hard enough.
this.
Yeah.
There's
Yeah.
a lot of that mental kind of drama we put on ourselves. So recognizing that it's a medical condition, and then once we recognize it is that, how do we kind of go about it? Then, I talk about the brain a lot. I love the brain. Side note, I actually wanted to be a neurologist. So this is, I think, how I kind of ended up. And I look at the brain not just from a anatomical standpoint, but really like that functional standpoint. And I talk about the three functional layers of the brain a lot with my patient. One would be that biological. So when you think about why we eat, the reason we eat or feel hungry is number one, the biological driver, which is actually based on our hypothalamus, right? This is the part of the brain where if is actually affected by our hormones, I'm sure we'll talk about that later. The second layer is that dopamine or reward pathway, which is actually based in our limbic system. And this is the one where, and I think everybody knows this feeling. I just ate dinner, but that cake is calling my name, so I'm going to eat it. So we eat not necessarily because we're hungry. We eat because of
That
social
looks
pressure.
good.
We eat,
Yeah, that'll taste good. I want some of that. I see some of that. I smell that. I want some.
Yes, the want, right? I want
Yeah.
more of that.
Yeah. I had a hard day. I deserve.
Yes. Oh my God, we so know that, don't we?
Yes.
And then that third layer of the brain is that prefrontal cortex, or the thinking brain, right? So this is where it receives the signals from both the biological regulator as well as that reward pathway, and then it makes a decision of, should I eat that or not eat that? But that prefrontal cortex, to do its very best, has to be optimized. Meaning we get sleep, we're not as stressed, because unfortunately everybody lives with stress. So kind of approaching it from that standpoint, and from that understanding, creating a plan based on the 4 pillars of nutrition, of obesity medicine, which is nutrition, physical activities, multi-component stress management, behavioral strategy, and the meds. I know that was a mouthful, so hopefully I'm sure we'll break it down there.
No, and I love thinking about it that way. I haven't broken that down with my patients in that same way of talking about, we've got these biological drivers, right? That kind of oldest part of the brain, the primitive part that helps, regulate hunger, appetite, fullness, is influenced by all of these hormones that we have in our body, right? Because if we didn't have these drivers, we wouldn't eat, right? If we knock these parts out, like a mouse brain, right? They don't eat and they die, right? That's obviously not okay.
Right.
We add the dopamine reward pathway, and that helps us to seek more caloric foods, because traditionally that would keep us alive, right? If you found a bush full of berries, you're going to eat as many as possible. You might like gather some and save them, because that also would promote your survival.
Right.
And now we have the prefrontal cortex, the newest part of the brain. And that, that's involved with planning and, long-term thinking. That's the part of us that knows we want to get our health online, that knows we want to take good care of our bodies and live a long, good, healthy life. The part that plans meals, the part that knows nutrition and knows that it should manage stress, but it needs a lot of support.
Yeah. That's also the habit forming. I like to talk about that too, in the sense of like, that's the future us, right? The long-term thinking person. And this idea of that 3 layers of the brain, I really credit that to Dr. Macklin. I didn't invent that. So Dr. Macklin, I think he tracks down to Canada. I remember watching one of his videos that one time, and it was just like, oh my God, that totally makes sense. It really it makes total sense.
Yeah.
But anyway.
Yeah. So if we've got, kind of this good understanding of how, how the brain works, how do we actually put things into practice to help ourselves? So if somebody's coming to see you for the first time, they've been struggling with their weight, their metabolic health, and they really want to get started, but they've had, kind of the same story, right, that we hear over and over again. I've gained, I've lost, I've gained, I've lost. where do we start using that brain science?
Yeah. So there's that knowledge, right? We all know that. And I think some of us physicians, we kind of know it, but it's how do you apply it?
Mm-hmm.
That's that magical, not magical, but that's that bridge from knowledge to
Right.
action, or actually knowledge to achieving it, right? It's the action. So utilizing that kind of 4-pillar approach of nutrition, everything is individualized. I think that's the way to really help somebody achieve what works for them. So I would look at it, okay, what are you eating? Where can we make small changes so that the ghrelin, which is the hunger hormone that makes the biological driver make us more hungry, so that ghrelin is not as high. So I talk about high protein, high fiber. I talk about the insulin, the hormone, and how we can kind of mediate that by, okay, can we make sure we have our fiber? Can we make sure we partner the complex carbs with any protein or healthy fats? So looking at those hormones as something like knobs that we can adjust, and how can we do that?
Yeah.
And I'm a big fan of 1% change, which I think that's Atomic Habits, James Clear. So I don't tell them. So that's why I always look at what are we eating now, and based on what they're eating, I will have a basic idea of like, okay, they're probably getting this many grams of protein, this many grams of fiber, and sometimes I talk about serving sizes with my patients. Really depends what they kind of like. And then from there, I'll make a plan. Okay, can you go up to 3 servings of vegetables from your normal 2 servings of vegetables, even though the goal is 5 to 7 servings.
Right. But if you're only eating 2, jumping from 2 to 7 is a big jump, right? Like that sounds undoable, but I might be able to do one more serving per day.
Yeah. And it's so funny because everybody would be always like, oh, I can totally do 5, Dr. Troutman. And I would say, that's amazing that you think you can do it. But, what can you do on your worst week? It's kind of how I sometimes phrase
I love that question. What can you do on your worst week?
Because, what's minimum? Now, if you can do 5 one day, amazing. But hey, I'm holding you to 3 servings a day. Yeah. And it sounds so basic, right? But because again, everybody, when they first come to see us, to see you and me, it's like, I'm 110%, kind of like where I was before, right? I'm going to do everything. I'm going to work out every day. And, sometimes we have to just temper that with, let's set achievable goals. Because if you set the achievable goal, you will hit your achievable goal. You get that dopamine hit. Yeah. And then you'll feel, I can totally rock this. So, yeah.
And the work required to make a 1% change and keep at it, right, is so much less than trying to make 20, 30, 40% change, right?
Absolutely.
It's not sexy though. I always tell people it's not sexy to make a small change. It does have a big impact, right? It does build in sustainable habits. But it's not, you're not going to post it on Instagram, it's not going to get a lot of attention, right? So we have to discount that part of it, right? Which has been kind of a traditional part of a lot of, kind of the weight loss story that we see, kind of out there in the world of like, look at this person who lost X amount of pounds, making this one change, so much unrealistic garbage that's out there. Right. But we're really interested in helping people support small, long-term sustainable changes.
Sustainable is the key word there, because I always ask my patient at the end of our visit. So I asked, so the changes that you've done, do you think you can do this long term?
Yeah. Right? Can you keep going? Yeah. Because
that's the barometer.
It isn't the loss, it's the maintenance, right? Right. Because any of us can, white knuckle through. Losing or, making some kind of, major progress, but can we sustain it, right? I can clean my whole house. Can I keep it clean?
Right? Yeah. Ask my daughter. Her room is always horrible. But so it's 1%. And I see that success in my patient with that approach. Example would be, and the second part would be, so first is nutrition, right? Second was physical activity. And we all know the goal is 150 minutes of cardiovascular aerobic activity per week, 150 minutes per week, twice a week of resistance training. We all know the standard, but
Yeah.
I've
But
had others that,
again, if we're doing none,
right,
we're going to start with 5 minutes. We're going to
Yeah.
start really small, right?
exactly. I tell my patients, hey, 10 minutes of walking twice a week. Can you do that? No, totally can do that. I can do more. Again, same thing. I meant with
Yeah.
like, I
I
can
can do
do
more than
more
that.
than
I can do an hour.
10 minutes, right? So, but I said, okay, cool, but let's, 10
Yeah.
minutes.
And then
That's all I
we
want.
pull back into that question. What about on your worst week? What?
Yes.
Yes. Yeah. I love that. And then tell us a little bit, because you and I practice obesity medicine, we are also comfortable with using medications and, really kind of talking about how those medications work. How do you incorporate that into conversations when you're talking about sort of the brain and some of these hormones and how they influence the picture?
Yeah, great question. For me, the medications are a tool, right? And they work actually in the same. That's why I always start with talking about the brain, because that's how medications work. They work on the parts of the brain that drive primarily the biological drivers, the hunger, hypothalamus area. So that is where medications like, Fermi, Ozempic, Zepbound, Mounjaro, that's where they all kind of like work on, plus other areas, depending on which medicine we're talking about. But it is a tool that only, meaning it's not going to work if we are not going to plan our meals. It's not going to work if we're not going to, do, or I should say, the medication alone may work short term, but then
It
again,
may work for a while, depending on which one we're talking about, right? Yeah.
Right.
So if you take Ozempic for a while or Wegovy, any of these kinds of medications, they will do something on their own for a while, but you won't have the long-term health and success that you're looking for, if that's all we're doing.
Right. And I can tell you, I have so many patients I've helped before where they would come to me already on the injectables from other providers, but nobody has ever talked to them about.
But they're not doing the rest of it. Yeah.
Right. So of course they come to me, I'm not losing weight. This medicine is supposed to help me lose weight. So this is where, having the assistance or help of an obesity trained physician will be helpful. Absolutely. Because I asked them, so what are you doing for your eating? What are you doing with this? Well, I'm just like not eating. Like, okay, that's not the way this would work out long term, right? So I go and then once I work with them and go over the 4-pillar pathway, the foundation, right? What we're eating, how we're moving our body, are we sleeping? Are we stressed out? What are you doing to lower your stress? They actually start losing weight. I didn't change the medicine.
Right. We didn't change the medicine, right? Yeah, I know I use the same sort of term, like this is a tool. And yes, some of our medicines, the injectables are going to work more robustly for people who are doing nothing differently, compared to some of our older medications, which have lower percentages, and yet I'm sure you've had this experience as well. Like I have people sometimes losing a tremendous amount of weight on metformin, which isn't even approved. We don't have a average percentage of weight loss, right? Because it hasn't been looked at that way. But sometimes using these medicines as a tool in conjunction with the things that we know to be good for your body anyway, nutrition, activity, stress management, sleep, can be tremendously successful. Yes, for sure.
Metformin, even the older anti-obesity medications like phentermine, I use that all the time, and I have patients that lose 30% of their total body weight on it.
Right,
because again,
way outside, kind of the usual. Typical. But again, I think you highlighted, right? Like that is the difference between working with an obesity medicine specialist, right? Who's really helping you to sort of tailor, your plan, as opposed to, just getting a prescription. Right. Because a lot of people, of course, are doing that. And, we just aren't seeing a lot of success with that.
Right. Yeah. Oh, just kind of side note, I think there is a paper out about metformin. And they studied it for weight loss. I think it's like 7%, 5 to 7%. Okay. Yeah. Okay. I haven't come across that one, but I'll take a look. Yeah, I'll email it to you. But I kind of use that to tell my patients, hey, it's not approved for weight loss, but again, in the right person. Cheap, easy, accessible. Right, and it has to be the right person. Okay, do you
Yeah,
struggle with
yeah,
insulin resistance? Do you have
yeah,
possibly, are you perimenopause, menopause, which is again characterized by an insulin resistance,
right.
or
Or
PCOS?
PCOS,
So those
right,
would be the
right.
perfect
Yep,
candidates for
yeah.
this medicine, and it might be what turns that knob a little bit for
Right.
them.
Might be the right knob,
Yeah,
to change that really helps you make the progress that you're liking to see.
yeah,
Yeah. Yeah. Well, I think this is great. I think this is a great way to sort of frame, these important conversations that we have with patients. For somebody who's out there listening and thinking, gosh, this is just great information. I'd really like to work with her. Tell people where they can find out more about you and your practice and have the opportunity to work with you.
yeah. So I'd love to help anybody that's struggling with their weight, and really help patients lose weight in a non-biased, really kind of
You're a
physician
shame-free zone,
and
right?
free. Absolutely. Yeah.
Yeah.
I practice in central Pennsylvania. I have a brick and mortar practice, which actually I am in my office right now in Pennsylvania, but I also see patients via telemedicine. I am at what we call a direct care weight wellness practice. And in addition to helping patients treat their obesity as a medical condition, I am also a sleep certified insomnia CBT-I clinician. So I love talking about sleep and helping people with their sleep without medication, as
Mhm.
well as I also focus a lot on perimenopause and menopause patients, and I will be opening an arm. So that's not weight loss per se, but that's
Yeah.
totally different. We
But
don't prescribe hormone therapy
they're
for weight loss.
important, sort of co-occurring sort of conditions, because of course you and I both see people who are starting to struggle with weight as they hit perimenopause, starting to have more sleep disturbance, kind of that feeds all of it. So I love that comprehensive approach. I love the ability to, really get the specialized care that people are looking for, so that they have success in all of those arenas. Their sleep is better, their perimenopause or menopause symptoms are managed, they're at a healthy weight, their metabolism is working well, like all of those things together. I love it.
It's all connected. And
Yes.
yeah, and my website is www.weightremedy.net. I'm also on Facebook, Instagram, not as much though, but it's gonna be the same name of Weight Remedy. I'd love to help you out if there's somebody that lives in Pennsylvania that needs the help.
Great. Great.
I'd
And
be
we'll have
happy to
links
help.
to that in the comments down below. So, Caissa, thank you so much for joining me. I think this has been a wonderful conversation, and I really appreciate you sharing your time and expertise with us today.
Thanks a lot, Megan. I had a great time.
Thank
Thanks.
you. All right, that's what we have for you today. Thanks for tuning in, and until next time, take care.